Awesome. Okay. Good morning, students. Today we'll be discussing some points on hypocalcemia and calcium metabolism. So, there are various calcium plays various roles in the metabolism. It has a vital role in the neuromuscular signaling, also in cardiac contractility, also in hormone secretion, and in the blood coagulation. Also, these are the main and very important functions where the calcium is involved. And coming to the homeostasis, calcium is mainly regulated by the parathyroid glands. So when parathyroid, the calcium sensing receptors sense low calcium in the body, they signal the parathyroid hormone is secreted. So it in turn stimulates the bone, where bone releases calcium into the body, and also signals the kidney, where 25 dihydroxycholecalciferol is converted into active form 1,2,5 dihydroxycholecalciferol, and also it stimulates the gut to absorb more and more calcium from the food. So this is how the calcium is regulated. And the total calcium concentration in the blood is 8.5 to 10 milligrams per deciliter, of which 50% is ionized and the remainder is bound to albumin. So not all the calcium which is floating in the blood is ionized. So only 50% is ionized and the remainder is bound to albumin. And the alteration in the serum protein concentration directly affects the blood calcium ion concentration. So there should be adequate albumin to have to show a proper calcium concentration in the blood. So definitely, if there is low albumin in conditions like nephrotic syndrome or any liver disease or any protein losing enteropathy, so definitely the concentration protein, I mean the calcium concentration in the blood is altered. So the corrected calcium, we should be, in those cases we should be calculating the corrected calcium, which is serum calcium plus 1.8 to 4.1 grams per deciliter minus patient's albumin. So this is the corrected calcium formula, so you should be remembering this. So acidosis also alters the calcium concentration. They should be remembering this. If the patient is acidotic, and if the patient is in metabolic acidosis, then you should be uh, calculating the corrected calcium. So, for example, we'll take an example. If the patient is in an acute illness and the serum calcium is 7.2 and the serum albumin is 2, so should we correct calcium in this patient? Absolutely no. So we should not be correcting the calcium in this patient because the serum albumin is very low. So the normal is around 4 albumin, and 4 to 4.5. So definitely if the serum albumin is low, then there will be a false positive kind of interpretation in the serum calcium. So you should be calculating the corrected calcium, so which is 8.88, so which is normal according to our corrected formula. So going back to the formula, we should apply this formula, should put on the patient's albumin and the corrected, I mean the serum calcium of the current serum calcium of the patient, which is plus zero point 0.8, and so we obtain this value uh, regard in this patient. So you should be remembering this. If the patient's calcium is low, never rush to correct the calcium and give calcium supplements or IV calcium in those patients, because always look for the serum albumin. If the serum albumin is normal and still the serum calcium is low, then you should be going forward correcting the calcium in patients. So you should be remembering this point. daily dietary intake of the calcium is 1000 to 2000 milligrams. So, and daily net calcium absorption is 200 to 400 milligrams, and intestinal absorption of active transcellular transport is 20 to 70%. The main site where the calcium is absorbed is duodenum and proximal jejunum. So this can be an MCQ, so you should be remember this. The main site where the calcium is absorbed is duodenum and proximal jejunum, and calcium carbonate and calcium citrate absorption. So these are the compounds which are usually absorbed. Uh, it's a small diagram. So extracellular fluid has 1 to 2 grams, and so if there is bone calcium of 1000 to 2000, so that will be in exchange with the gut and with also the kidney. So there is a regulation from the extracellular fluid. So the main sources are the bone, kidney, and the gut. So these are the main sources where the calcium is being regulated. And calcium reabsorption in kidney, 8 to 10 grams per day of calcium is filtered by glomeruli. 2 to 3 percent appears in the urine. So absorption is 65% from the proximal convoluted tubule, which is passive diffusion, which is by passive diffusion, and 20% from the descending from the parasilin one thing channels, and from 10% from the descending from the distal convoluted tubule. So this is how the calcium is absorbed. So more, if the patient is secreting more and more calcium, he can be prone to uh, kidney stones. So calcium phosphate or this kind of stones can be formed. So definitely you should also regulate the calcium secretion also. So if there is more and more secretion of calcium, the patient can be prone to nephrolithiasis, other kinds of. So parathyroid hormone is also one of the main regulatory hormone for the synthesis for the secretion from the regulation of calcium in the body. So it is an 84 amino acid single chain peptide with two terminals, and parathyroid hormone increases steeply to maximum value of 5 times the basal rate of secretion as the calcium concentration falls from 7.6 to 8.0. So this is how the calcium parathyroid hormone is secreted. So when the blood sends when there is low concentrations of calcium inside the blood, so which is sensed by the calcium sensing receptors in the parathyroid, then the parathyroid secretes parathormone in response to low calcium levels. So parathormone has a direct effect on the bone and kidney, whereas indirect on the intestine. So it has a direct parathormone breaks down the bone to release calcium, and it also stimulates to it also increases the absorption of the calcium from the kidney, and also stimulates to also stimulates kidney to synthesize more and more vitamin D. In fact, the vitamin D which is produced from the kidney will stimulate the intestine to absorb more and more calcium from the gut. So this is how the calcium is regulated by the parathormone. And hypomagnesemia also impairs parathormone secretion, and calcium interacts with calcium sensing receptor, which is a G coupled receptor. It's a calcium sensing receptor present in parathyroid and C cells and brain and kidney. So these are the main sites where the calcium is being sensed. If there is low calcium, then it will stimulate the parathyroid. And CASR mutation, the loss of function and gain of function is there. If there is a loss of function, then it will not recognize any low calcium levels, and if there is a gain of function, then there is an increased stimulation of kidney and gut, and so patient might lead into hypercalcemia. So these are the causes of hypocalcemia. So we'll just go through. Low parathyroid hormone levels and hypoparathyroidism can be in parathyroid agenesis, or it can be isolated, or can be in DiGeorge syndrome, or parathyroid destruction, which is usually in surgical radiation and infiltration by metastasis and systemic diseases and autoimmune diseases. So why the parathyroid gland is viable for destruction during surgery? Because it is right behind the thyroid, and it is very vulnerable if the patient is undergoing thyroidectomy, subtotal thyroidectomy or complete thyroidectomy, because these glands are like embedded inside the parathyroid, and they are very vulnerable for during the surgery. If the thyroid is removed, it can also injure the parathyroid gland, and which can also be excised with the thyroid. So usually the surgeons are very careful when they're doing the thyroid surgery, because to preserve the parathyroid and to remove the thyroid. So reduced parathyroid function and hypomagnesemia and autosomal dominant hypocalcemia. So these are the low parathyroid hormone causes. So which is other one is parathyroid destruction, the other due to agenesis, or any improper development during the birth, or any mutation, or any other congenital anomaly, and during the reduced and it also used during a reduced parathyroid function. And high parathyroid hormone levels is seen in secondary hyperparathyroidism, seen in vitamin D deficiency or impaired 1,2,5 dihydroxy cholecalciferol production. It's also called as calcitriol. This formula, which is 1,2,5 dihydroxy vitamin D or cholecalciferol, is also called as calcitriol action or impaired vitamin D action. And nutritional vitamin D deficiency or poor intake or absorption. So nutritional vitamin D, if the patients are very nutrient deficient, if they are not taking enough vitamin D, or if they are not exposed to sunlight, so usually the vitamin D is synthesized from our skin. So if there is the morning wavelengths of the light usually produce the vitamin D. So if there is no adequate sunlight exposure, then the patients might fall into the vitamin D deficiency. So if there is any renal insufficiency with impaired vitamin D production, so if there is any renal insufficiency in the sense, if the patient is having any chronic kidney disease, or any renal cystic disease, where there is destruction of the renal parenchyma, so there is no enough conversion of 25 to 120 inactive to active form of vitamin D, so there can be deficiency. And vitamin D resistance, including the receptor defect. So if there is any resistance to the vitamin D receptors, so it can also have impaired vitamin D deficiency. So parathyroid hormone resistance syndromes, like parathyroid hormone receptor mutations and pseudo hypoparathyroidism, which is a G protein mutation, which we'll discuss. And drugs like calcium chelators, inhibitors of bone resorption, and like bisphosphonates and plicamycin, and such kind of drugs, which are very vulnerable for calcium, and for bone resorption, sorry. And altered vitamin D metabolism can be seen by phenytoin and ketoconazole, so should be remembering these also. And miscellaneous are acute pancreatitis, rhabdomyolysis, or hungry bone syndrome, or parathyroidectomy, or osteoblastic metastasis with marked stimulation of bone formation, and prostate cancer. So these are the causes, so briefly we have described. And kindly try to remember these causes and try to mention some of them. This table is from Harrison, so you can go through if you have any doubt. Uh, So, what are the genetic causes which we have discussed? So, DiGeorge syndrome is a catch2 mutation, which is by the TBX1 gene. So, in this there is parathyroid agenesis. So, definitely you should be remembering DiGeorge syndrome when it comes to uh, parathyroid gland. So, and also familial hypoparathyroidism, which is a GCMB mutation, and Kenny-Caffey syndrome is a TBC, and Sanjit-Sakti syndrome and autoimmune polyglandular syndrome type 1, and Kain-Sayre syndrome and Melas syndrome. So try to briefly remember these syndromes where the calcium metabolism is involved. So if there is an inactive parathyroid hormone, then there is pseudo hypoparathyroidism, or there can be vitamin D deficiency. So vitamin D deficiency is further, it can be a vitamin D receptor defect, or it can be due to CKD. So pseudo hypoparathyroidism, the low calcium level and elevated phosphate with elevated parathyroid levels. So why it is called pseudo? Because the calcium is low, but phosphate is elevated, but still the parathyroid hormone levels are elevated. So a defective parathyroid hormone dependent activation of the stimulatory G protein complex. This is why it is called pseudo. And when there is parathyroid hormone, the G protein coupled receptor here, the downstream signaling is not happening here. But again, what is happening is there is osteoblast cell. The stimulation causes uh, phosphatidylinosyl phosphate 2 to the IP3 and DAG conversion of and stimulates the osteoblast cells. So this is how it regulates. So coming to the classification of the pseudo hypoparathyroidism and pseudo hypoparathyroidism. So what happens in pseudo hypoparathyroidism 1A? Uh, There is hypocalcemia and hyperphosphatemia, yes, and there is the response to the urinary cyclic AMP to PTH. It is reduced, and serum parathormone is increased, and G alpha subunit deficiency. Definitely there is GS alpha subunit deficiency. And coming to the pseudo hypoparathyroidism, there is no hypocalcemia, but there is normal response to urinary cyclic AMP. And in pseudo hypoparathyroidism 1B, there is hypocalcemia with hyperphosphatemia, and there is reduced urinary cyclic AMP to parathyroid, and there is increased serum parathyroid. And parathyroid pseudo hypoparathyroidism 2 is there will be increased there will be increased phosphate and low calcium with a normal response to the cyclic AMP to PTH, and there will be increased serum PTH. So there in pseudo hypoparathyroidism there is G alpha subunit deficiency, and in so in there is Albright's hereditary osteodystrophy. So in this condition, if there is Albright's hereditary osteodystrophy, if the pseudo hypoparathyroidism 1A can have Albright's hereditary osteodystrophy, and a pseudo hypoparathyroidism can also have Albright's hereditary osteodystrophy, and the pseudo hypoparathyroidism 1B and 2 can don't have any Albright's hereditary osteodystrophy. And acrodystosis with hormonal resistance is the same as it has low calcium levels and more increased phosphate levels. There is normal response to the cyclic AMP, and there is increased parathormone secretion, and there is Albright's hereditary osteodystrophy. Or what? Let's describe briefly about Albright's hereditary osteodystrophy. So, patient will present with short stature, a round face, and intellectual impairment. There will be early onset obesity and skin skeletal abnormalities like brachydactyly, and heterotrophic calcifications are seen. So, this is Albright's hereditary osteodystrophy. And some insight on pseudo hypoparathyroidism and pseudo hypoparathyroidism. So this is how you'll see there's a patient with pseudo hypoparathyroidism with and Albright's hereditary osteodystrophy. There is demineralization of the bone and shortened fourth metacarpal. So there is totally a short fourth metacarpal, and so you can, this is very prominent, you can see, and is like short stature, obesity, and other features of Albright hereditary osteodystrophy are seen. Coming to the CKD, impaired production of the active form of vitamin D, which is calcitriol, uh, is very prominent in patients with CKD. They usually require vitamin D and calcium supplementations. So which is you should be remembering. So that due to destruction of the renal parenchyma and due to the shrinking of the kidneys, so the kidney is unable to produce adequate vitamin D conversion from inactive form to active form. So usually the reaction is from the 25 dihydroxycholecalciferol is converted into 1,2,5 dihydroxycholecalciferol in the presence of the enzyme 1 alpha hydroxylase. So this 1 alpha hydroxylase is present in the kidney. So this enzyme converts the conversion of inactive form to the active form. So the active form of vitamin D is sensitized in the kidney. So if there is any increased levels of fibroblast growth factor 3 in the bone, or if there is any hyperphosphatemia and low calcium levels in the kidney, and usually what we do is phosphate restriction and adequate calcium intake of 1 to 2 grams per day with calcitriol, which is also 1,2,5 dihydroxycholecalciferol, and you should be giving 0.25 to 1 microgram per day, and sevelamer is a phosphate binder. So this is how you treat the patients with CKD who are calcium and vitamin D deficient. So the goal is to restore calcium level and prevent osteomalacia and secondary hypoparathyroidism. So the recommended level of parathormone is 100 to 300 picogram per milliliter. So we should be preventing a secondary hypoparathyroidism and to restore calcium level and to prevent osteomalacia. So this is how you treat a patient with CKD and to maintain calcium metabolism. So hypomagnesemia, so if there is severe hypomagnesemia of less than zero point 0.4 millimoles per liter, so the mechanism is due to impaired parathormone secretion and impaired synthesis of vitamin D and cellular resistance to PTH. So this is how the hypomagnesemia develops. So vitamin D dependent rickets, I think you already know, is mutation in the 1 alpha hydroxylase in type 1, and the mutation is gene encoding vitamin D receptor in type 2. So there is definitely low level of active form of vitamin D due to 1 alpha hydroxylase deficiency, since there is no conversion from 25 to 125. So there will be low levels of active form of vitamin D, and end organ resistance is absent, and end organ resistance is present in type 2, and clinical features are hypocalcemia with tetany, convulsions, and osteomalacia, and type 1, and hypocalcemia with tetany, convulsions, osteomalacia, and with alopecia in type 2, and the treatment is vitamin D exclusively in type 1 patients and just calcium inclusion in type 2 patients. So clinical features, what do we see in patients with hypocalcemia? There will be perioral paresthesia, tingling of the fingers and toes, and spontaneous and latent tetany, seizures, laryngospasm, growth plates abnormalities, and there will be mineralization defects, and basal ganglia calcification and extrapyramidal disorders, and papilledema and raised intracranial pressure. So these are all the signs and the clinical features what we see in patients with hypocalcemia. So what how do we see there is Chivostex and Trousseau sign? So what do you gently tap on the cheekbone, then there is sudden contraction and the deviation of the angle of mouth towards the tapped side. So which is when there is low levels of calcium. So it's Chivostex sign. So and the Strossau sign is when you inflate a BP cuff and you keep it for like 20 to 30 seconds, around 1 minute. So they immediately you see the patient having carpopedal spasm, so which is a positive sign for hypocalcemia. So these are the two signs where you see when there is low calcium levels. So it's a Chivostick sign and Trousseau sign, should be remembering. So there is severe symptomatic hypocalcemia is an emergency condition that requires immediate attention to prevent seizures and death from laryngospasm or cardiac cause. So since calcium is an important for the myocytes, cardiomyocytes. So then because if there is low calcium, there is improper contractility of the cardiac muscle. So there can be arrhythmias and sudden cardiac death in patients with severe symptomatic hypocalcemia. So definitely you should be treating immediately with intravenous calcium, which we'll be discussing further. So other signs of tetany is the many signs. I'll just read out. Just try to remember. Poole-Schlesinger sign and Schludge sign and Kashida thermic Escherichia sign and Hoshinger sign and Peroneal sign. Just briefly go through is a forceful abduction and elevation of the arm to produce tension and the brachial plexus, and forceful flexion of the thigh on the trunk while the leg is extended and stretched to stretch the sciatic nerve. So this is a technique, and the finding what we see is tetanic spasm of the muscles of the forearm, hand, fingers, and the spasm muscles of the leg and foot. Okay, and the short sign is mechanical stimulation of the protruded tongue, and there is transient finding. What we see is transient depression and damping of the site of the stimulation. Okay, and Kashida's thermic is application of the either hot or cold irritants, and you can see hyperesthesia and spasms. And Escherichia sign is percussion of the inner surface of the lips or percussion of the tongue, which causes contraction of the lips and masseter and the tongue. And Hoshinger sign is pressure of the inner aspect of the biceps muscle, spasm and contraction of the hand can be seen. And peroneal is tapping over the common peroneal nerve as it winds around the neck of the fibula. You can see dorsiflexion and eversion of the foot. So these are some important signs of tetany. So these signs can be asked in MCQ examination. So if you are aware, then you can answer these questions. So there are minor ECG changes. So there is low complex this thing in the ECG, and we'll see flattened T waves. So you can see the flattened T waves. Those are minor changes. So basically, in the ECG, what happens is the calcium plays a vital role in the depolarization, the repolarization of the. So when there is PQRS, so there is delayed repolarization, and there is prolonged QT interval. So there is, you can see there is prolonged QT interval. So this is the T wave, and this is the QRS complex. So you can see there is a prolonged QT interval. So these are the main changes which you should observe when there is hypocalcemia. So calcium plays an important role in the repolarization phase of the cardiac cycle. So definitely there will be a QT prolongation. So how do you approach a diagnostic approach? Since you see low serum calcium levels, then you see for albumin also, and if there is normal albumin, then check for serum parathyroid hormone levels. Then if there are low parathyroid hormone levels, then what possibilities you can see are parathyroid agenesis or parathyroid destruction or genetic causes. And if there is elevated parathyroid hormone, then there will be secondary hyperparathyroidism, which is vitamin D. And then you go for vitamin D. If vitamin D is low, there will be nutritional vitamin D deficiency. If the vitamin deficiency is non again low, then there can be signs of renal insufficiency also. So you should always do an ultrasound to check for the kidneys and ultrasound of the neck to check the parathyroid glands if there is any agenesis or anything. So this is how you approach. So treatment is depends upon the severity of hypocalcemia. So acute condition in if there is emergency, if there are any cardiac changes and any ECG changes, and the patient is severely symptomatic, then definitely we'll go for intravenous calcium. So injection calcium gluconate 10 milliliters, just 10% weight by volume, this 90 milligrams intravenously diluted in 50 milliliters of 5% dextrose or NS, given over 5 minutes. So this is given in acute condition. And continuing hypocalcemia, and given IV infusion of 10 ampules of calcium gluconate or 900 milligrams of calcium in 1 liter of 5% dextrose, or normal saline over 24 hours. And definitely also correct magnesium also. And in chronic hypocalcemia, yeah, can give calcium supplements of 1000 to 1500 milligrams, and vitamin D or calcitriol of 0.25 to 2 micrograms per day can be given as treatment. So parathyroid hormone is a recombinant parathyroid hormone. If the patient parathyroid glands are destructed, and then to maintain the parathyroid hormone levels, the recombinant parathyroid hormone is recently approved for treating refractory hypoparathyroidism. So can be given. And nutritional vitamin D deficiency, a low dose vitamin D of 50,000 units 2 to 3 times week for several months can be given for nutritional vitamin D deficiency. And vitamin D deficiency due to malabsorption, and 10,000 1 lakh units per day of vitamin D can be given. Malabsorption, the goal of therapy is to normal serum calcium levels and to avoid hypocalcemia. Okay, we have come to the end. So there is some brief insight on hypocalcemia. Uh, if you have any doubts or any kind of any topic you want to discuss in further classes, please let me know in the chat box, so that I'll come prepared for that proper topics and give one or two small topics or one big topic would suffice. So please let me know if there is any doubt or any a topic specifically you want to discuss. Okay, so I don't see any messages. So hopefully, I think people are have completed that portion. So if you have any doubt or any topic you want to discuss again, so please let me know. Until then, Happy New Year.